Good afternoon, everybody. Thanks for joining us on this webinar today. I'm watching the attendee count go up and up. So as usual, we're going to give just a minute or two to let folks kind of trickle in here before we jump in. So again, thanks for spending your afternoon with us. My rainy afternoon, your hopefully sunny afternoon. Or for a lot of you, it's probably not even afternoon. Okay, well, why don't we get started? We'll let we do have a bunch of kind of housekeeping slides to get through anyway, so we'll let the folks that are still trying to get here while we go through that. Okay, my name is Eric Christensen. I'm part of the ADAM community and part of Payer Watch. Grateful to have everybody join us today. We're really grateful for Richelle Marting taking some time with us again. Long time collaborator and contributor to all things ADAM, so it's always a really great discussion when Richelle's able to join us. Very quickly, we want to make you aware of the options for joining. If you're having trouble with audio, maybe try dialing in. You can download these slides, which might be a good way to find that number again. As you see on our first slide here, here's the call-in phone number and the access code, but that is on the download. So you might want to pull that up very quickly. And then please submit any questions that you have, and we're going to try to get to those at the end. And then as always, we'll try to answer those post-webinar for any that we didn't get to during our call today. For anybody that has not been a part of ADAM, that might be new to this webinar, the Association for Healthcare Denial and Appeal Management is it's really the only association out there for denials and audits and appeals. Our mission really is to create a community of appeal specialists, like-minded folks that deal with these challenges from the payers in some fashion, provide education, training, resources to assist in that battle. The association was created through very generous support of Payer Watch. Payer Watch serves hospitals and health systems across the country, both through Appeal Masters, which is the appeal support services side of the company, as well as through technology. Veracity is a software that helps automate and accelerate that whole workflow of receiving a denial or an audit and getting an appeal out the door in a timely fashion, having all the tools you need right at your fingertips to expedite that process and make it a lot easier on your appeal specialists. CEUs are being offered for today's webinar. In order to be eligible for that, there's three things you got to meet. You do have to be an ADAM member. You do have to attend this webinar live, so you're here. That makes you eligible if you're an ADAM member. And then you have to complete the survey that will pop up at the end of this webinar. We will email those certificates out once we've processed that. It's usually within about a week. That will come from info@adam.org. So make sure that that's whitelisted. Make sure that, if you don't receive emails from that, check with your IT department. Make sure it's not in your spam folder, all the normal stuff. But feel free to email us as well at info@adam.org if you're having any trouble getting the CEUs after this. This is a list of the CEUs that we are currently offering. A lot of this information, I'm not going to read through all of it. You can pull up that handout and read down through it. Otherwise, we'll be here all day long. Just a quick note for the Medco, there are, well, we need to let you know, first of all, that we're not receiving any financial or any commercial assistance from the Medco for this activity. This is a statement again from them. And again, you can pull this up and read through all of that, but we just need to make you aware of that before we jump into the portion where we're actually training and educating here. There is there are additional steps you need to take in order to obtain that specific CEU, that certificate from a Medco. This slide shows you those steps. You'd have to go to this website, jump through the couple hoops there that are made for you before you could get that CEU. I do want to make you aware of our June webinar. We have that scheduled, and the registration link is live now. That's going to be on June 25th, 1 to 2 p.m. Eastern Time. Again, CEUs will be offered for that webinar, so hope you can join us. The best way to register is go ahead and go out to the ADAM.org website, and you'll see the link to that right there. Okay, this next one, as always, is our disclaimer. I do have to read this verbatim, so just bear with me. The Association for Healthcare Denial and Appeal Management, ADAM, publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ADAM members. ADAM does not certify the accuracy or authority of these materials. These materials are distributed and present information to be used by ADAM members in conjunction with other research deemed necessary in the exercise of ADAM members' independent professional judgment. ADAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors and do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. And then just a quick rundown of our learning objectives. So the conclusion of this webinar, you'll be able to determine common Medicare Advantage plan challenges with the 2-midnight benchmark, identify strategies that work when responding to plan details, and determine when the CMS complaint process should be initialized. With that, I am going to turn things over to Richelle Marting and Dr. Kendall Smith to introduce themselves and get on with the presentation. Thanks.
Dr. Smith, I'll let you go first.
Oh, okay. I was going to say that was not my picture, but yeah, here I am. So Kendall Smith, I've spoken with you all, I think, far too many times. This is primarily going to be Richelle presenting today. So for those of you sick of my voice, fear not. We have a much more intelligent and engaging speaker today. I'm just here for some clinical commentary. Hospitalist by background, you are, and CDI director. So very appreciative of Richelle's contributions and efforts today.
Thank you, Dr. Smith, and to Payer Watch for having me. I'm an attorney by training, and a lot of my background, even in private practice as an attorney, has been in healthcare reimbursement systems. I'm an RHIA and a certified coder before I was an attorney, and I've really used that background in a lot of the legal and HIM and CDI denials and appeals related work that I've done throughout my career. So really appreciate Payer Watch inviting me today to talk about one of my favorite topics, Medicare Advantage plans and the 2-midnight benchmark, not to be confused with the 2-midnight presumption, but we'll get into that distinction in just a little bit. So I'm going to give you just a little bit of a roadmap of what we're going to talk about this morning or this afternoon, depending on where you're calling in from. And starting with kind of a 101, some basics, but I think it is so critical in understanding Medicare Advantage plan rules and the 2-midnight benchmark and the criteria to decide if a patient should be in an inpatient level or status of care in the hospital versus observation or some other level. You've got to understand kind of the primary and fundamental requirements of Medicare Advantage plans to cover basic benefits and what that means. And then we'll talk about the circumstances when Medicare Advantage plans can create their own internal coverage criteria or rely upon commercial proprietary coverage criteria to make coverage and payment decisions, but the limitations around doing so when they are permitted to do so. And then I want to talk about the 2-midnight benchmark from a pre-service workflow, sort of that concurrent review, notice of admission, getting prior authorization for an inpatient status, peer-to-peers, appeals, all on that pre or that front end of care. And then I also want to talk about the 2-midnight benchmark and Medicare Advantage plan rules when it comes to a post-service or a post-claim review. We're going to talk about some nuances and some rules governing that process. And then I want to share with you some of the things, some of the strategies that we've tried to use in both that concurrent and that post-claim review process, particularly with Medicare Advantage plans that have helped and started to move the needle a little bit and improve, I think, Medicare Advantage plan compliance with the 2-midnight benchmark, increase approvals, and increase adherence to our contracted rates for hospital inpatient level of care. So go to the next slide, please. All right, there are several resources that I think you need to have on hand. And I've just put the URL here so that you can go find them. I have these both bookmarked on my internet browser and saved to my desktop because I am in these documents so often. One of them is the Medicare online manual. It's called the Managed Care Manual. But it is basically like our internet-only manual, benefit manual, claims processing manual, but it's the MA version of that. The reason I say you need that document bookmarked to your browser, saved to your desktop, is that there is language in this internet-only manual from CMS that existed prior to some rules and regulations that went into effect in 2024. And the text in this manual has been in effect prior to 2024 and really clearly discusses some rules, some parameters, and some safeguards for providers and for patients when it comes to MA plans giving prior authorization and whether or how they may disregard, rescind, or revoke prior authorization later. We're really going to talk about that when we get to the post-service or the post-claim component of some of the challenges we see with MA plans and the 2-midnight benchmark. So that's one resource. Another one that is so important to have on hand is the 2024 final rule for Medicare Advantage plans. And in this rule, we saw some of this policy that has for a long time lived in the Medicare manual, and we saw it codified into federal regulation surrounding prior authorization, what it means, when and how MA plans must honor prior authorization, and when or if a Medicare Advantage plan could reopen a prior authorization decision to arrive at a different decision later. This is also where we gained regulations with really good protections for both patients and providers, professionals, and facilities surrounding coverage criteria. When can a Medicare Advantage plan even create their own or rely upon commercial coverage criteria that don't live in traditional Medicare rules? And then when they can, what are some of the guardrails around how they use those coverage criteria? Excellent resource. And I'll talk this afternoon about some of the particular pieces of that rule that I frequently reference. And then another document that I think is incredibly helpful with some really good rich text from CMS about how CMS interprets some of these policies and regulations is a memo that CMS wrote to all Medicare Advantage organizations February 6th of 2024. And if you just search, I've got the URL here, but if you just searched CMS memo to MA plans February 6th, 2024, you'll find it as well. I bookmark it, I have it saved on my desktop, and I'll show you why in just a few minutes. All right, let's go to the next slide. So I want to start with this very most basic and fundamental concept that really lays the groundwork for everything else that we're going to talk about with respect to the Two-Midnight Benchmark and Medicare Advantage plans. And this very basic, most fundamental principle from the beginning of the Medicare Advantage program is that Medicare Advantage plans must cover and pay for basic Medicare benefits in a manner that is no more restrictive than traditional Medicare. I'm going to say it one more time. Medicare Advantage plans have to cover and pay for basic Medicare benefits and in a manner that is no more restrictive than traditional Medicare. Next slide. And so the way that MA plans can do this, really there's three options. An MA plan could have its own healthcare providers. An MA plan could have its own hospital, or a hospital could have its own MA plan, hire their own physicians and healthcare professionals, and deliver Medicare benefits directly to their members. So they can provide coverage of those basic benefits directly. That's not typically the model. That's not the most common model, of course. They can do this under arrangement or by paying for the care. Those are the three options. Those are the three ways in which a Medicare Advantage plan provides basic Medicare benefits to their members. That last one, paying for the care, in theory, is the way that the model is typically designed, by contracting with hospitals or healthcare professionals to deliver the care, and then the plan pays for it. Next slide, please. So I want to kind of follow the path of this rule. This, like I said, has been in effect since the beginning of the Medicare Advantage program. And it's not just a policy, it's a statute. It's part of what Congress enacted to allow the Medicare Advantage programs. So there it is, black and white. There's the citation. There's no pop quiz on the citations later, but I want you to have them. MA plans shall is mandatory. That is not optional. MA plans shall provide to their members the benefits that are available under traditional Medicare. So then the Department of Health and Human Services, Department of Health and Human Services has regulations that then interpret and apply that statutory directive from Congress. And Department of Health and Human Services said all MA plans have to cover all of those services that are covered by Part A, which is our hospital inpatient services, or Medicare Part B. They can cover more, they can't cover less. And then lastly, in that Medicare manual that I told you to bookmark or to save on your desktop, it's also got language. An MA plan must provide its enrollees in that plan with all of the Part A and Part B original Medicare services. So it's consistent from statute down to administrative guidance. But then how that happens, particularly when there aren't specific rules under traditional Medicare, or when there are, that's where we start to get in some room for interpretation. And that's how policy has kind of evolved, trying to address these different gray areas of interpretation. So let's go on to the next slide.
Richelle, I'm gonna throw a curveball at you if I could real quick. Just a question popped in my head. So in the post Chevron era, with the Supreme Court's ruling last year, moving away from deference to from agencies to the judicial system, do you see any of these directives that you just went through being litigated or challenged, or do you think this is so set in stone that we're not going to see any movement in it for foreseeable future as far as how it's interpreted?
Yeah, it's so interesting because so far from Congress to policy has been consistent. But there are some areas of interpretation, and I'll give you an example, even in the Two-Midnight Benchmark context for hospital services. An MA plan may say that we didn't authorize an inpatient level of care. we authorize observation status or level of care.
Hmm.
An MA plan might say, we are providing basic Medicare benefits. And that's what Congress directs. The hospital approach and CMS's policy and interpretation has said, but you're doing it in a way that's more restrictive than traditional Medicare if the 2 midnight benchmark was met and yet you are not covering it as an inpatient service. So I think there is some part of that policy and interpretation that Department of Health and Human Services has naturally had to develop some rulemaking, but so far we haven't seen that particularly challenged by MA plans. And I would just venture to guess if it were, we did see a lot of additional spending in that Part A space, or Medicare Advantage on hospital services last year in 2024, when some of the regulations changed, probably would have been a time that we would have seen a challenge as soon as those final rules were announced, but we didn't.
Gotcha. Thanks.
Absolutely. It's a good
Always.
question. And we're going to continue to see CMS policy. So it will be interesting if there's a particular breaking point for an MA plan that may challenge some of this policy. So I've talked a little bit about this already. This is a quote. I try to put it in quotes so I don't mess it up. And this talks about what an organization determination is from a Medicare Advantage plan. And the significance of the way an organization determination is defined is that it implicates what appeal rights you have, and whether and how the MA plan can use coverage criteria to arrive at an organization determination. So it's basically a decision about the plan, whether the plan will or will not cover services. It's anything about the coverage and payment. I put that phrase together, coverage and payment, because we sometimes see language that an MA plan is covering, but for various reasons will not pay for a service. They considered it bundled into a previous stay or some different rationale. So an organization determination is coverage and payment of a benefit. And an organization decision includes a refusal to provide the service, providing either directly, under arrangement, or by paying for the service. A refusal to provide the service, or in whole or in part, including the type or the level of service. Type or level might be inpatient versus observation. That's either a type of service or a level of service. So bringing the concept of inpatient status versus observation back to the table, it is a decision that's either refusing to provide that basic benefit of hospital inpatient services in whole or in part, including the type or the level of hospital services. Next slide. So when we have an organization determination about whether a Medicare Advantage plan will provide directly, under arrangement, or by paying for a service, a basic Medicare benefit, then there are some rules of the road, some guardrails and some parameters that MA plans have to follow. Now, I've got some page numbers listed on this slide, and this comes from the second out of the third reference that I gave you that you need to have bookmarked or you need to have saved on your desktop, and now you can just control find these page numbers so you know where to pull this information up. MA plans have to follow coverage and benefit conditions under the traditional Medicare program when the traditional Medicare program's rules are fully established. For example, it's pretty well established under the traditional Medicare program what the inpatient only list is, right? Every year we get an update to the inpatient only list. If a code is on there, it must be performed in an inpatient setting. Now, a Medicare Advantage plan could add to that list. They could give their members heightened inpatient benefits for procedures beyond what traditional Medicare does, but they can't take away from it. They can't shorten that list or make it smaller. That would be greater access to a higher level of care. They can do that, but they can't take away. The rules for inpatient status or level of care in the hospital are also pretty well established. In fact, the 2024 rule references that they are fully established. The 2-midnight benchmark, the inpatient only rule, or the case-by-case exception. And it goes on to address some other scenarios. Skilled nursing facility care, we know what those criteria are. A qualifying 3-day inpatient hospital stay, and so on. Now, an MA plan could shorten that requirement or eliminate the requirement for a 3-day stay, but they can't make it longer. They can't go from 3 to 5 or 3 to 10. They could increase access to skilled nursing facility services beyond what traditional Medicare would do, but they can't restrict it. So these were some examples that we got in 2024 where CMS says these rules are pretty much fully established. Next slide. What that means when those rules are fully established is that the Medicare Advantage plan cannot create their own rules that are more restrictive or that would change those basic Medicare policies. Dr. Smith?
Quick question. So it seems clinically to be much easier and straightforward to get a patient from acute inpatient into inpatient rehab if they're covered under traditional Medicare versus, and I think if you look at the data of length of stay and patients accessing inpatient rehab benefits for MA plans, there seems to be a disconnect between those benefit levels. Do you have any feeling as to whether that's actually being adhered to or success in pointing this out to MA plans when they
Oh,
appear to be deviating from the rules?
absolutely. Yeah, and I've heard a couple of things as I talk to MA plans about that exact scenario. And there's a couple of issues with it. Number one, we're keeping the patient in the hospital for 2, 3, 5, 6, 8 days while we wait for authorization for that post-hospital placement, right? Or we go to a peer-to-peer and then we appeal and we're waiting for that process to move through. I hear from MA plans that there's an OIG report from several years ago indicating maybe traditional Medicare was overpaying for inpatient rehab in circumstances that patient didn't meet criteria. So they're kind of citing that OIG finding. But you're exactly right. With the traditional Medicare setting, we don't have prior authorization to move the patient to the next level of care. The risk is if we're wrong, and we are reviewed later, you get no payment if you tried to put a patient in inpatient rehab inappropriately. Whereas with prior authorization, if an MA plan were to deny prior authorization for inpatient rehab and in turn goes to skilled nursing facility or home with home health, there's some care provided that would still be paid as a result of that prior authorization. But I think there is definitely disparity between the two programs, and who's right and who's wrong is probably somewhere in between, right? But what we find often in those situations, maybe it's not well articulated in the MA plan decision letter why they're not covering or approving inpatient rehab, and tying it back to a traditional Medicare program or requirement that wasn't met. We're not seeing that type of rationale. And so in these circumstances, when traditional Medicare's rules and coverage criteria are fully established, like hospital inpatient care, MA plans cannot create and apply their own criteria. We're going to talk about what that means and the tiny little piece of the 2-midnight benchmark that may allow certain coverage criteria to come into play. Let's go to the next slide. When traditional Medicare rules are not fully established, then an MA plan can create or use their own coverage criteria. And when I say their own, it may be something the plan that develops themselves, or it could be a commercial product, a commercial tool. And we're all familiar with different tools for inpatient status decisions. But they can only do that in circumstances where traditional Medicare rules are not fully established. Medicare doesn't define what it means to be fully established. They only define what it means to not be fully established. And there's 3 situations when traditional Medicare rules are not fully established. If there is some kind of additional or unspecified criteria needed to interpret a provision, and in that situation, the clinical benefits, not financial benefits, the clinical benefits of the criteria that the plan will use are highly likely to outweigh clinical harms. And CMS said, this isn't just a boilerplate statement you put on a policy. We expect a plan to do an analysis. What are the potential clinical benefits of a coverage rule? What are the potential clinical harms? And how does this coverage criteria, the benefits outweigh harms? If you've ever read a local coverage determination from a Medicare administrative contractor, they go through that analysis. They cite tons of sources, like them or love them. They do at least have sources that they're bringing together and citing as they formulate different criteria. So that's one circumstance when we need additional and unspecified criteria, and if that's the case, whatever clinical criteria being used by the plan are highly likely to outweigh clinical harms. The second is when there's a national coverage decision or a local coverage decision that explicitly, not implicitly, explicitly allows for coverage in other situations. The MA plan can describe what those other situations are. And then lastly, if there is a complete absence of applicable medical rules, Medicare rules, coverage criteria can be developed. Well, that's not the case for inpatient status. There's not a complete absence. And this isn't based on an NCD or an LCD. So if an MA plan could use some sort of coverage criteria to decide inpatient versus observation, it really would have to fall under A. And we would have to have some kind of clinical benefit highly likely to outweigh clinical harm to use those criteria. Next slide. Okay, now, if Medicare's rules are not fully established, then the MA plan could potentially consider using coverage criteria in one of those 3 scenarios. And if we're talking about inpatient status, we're going to be focused on that first one, that there's some kind of unspecified criteria that we need some explanation, and the clinical benefits are highly likely to outweigh clinical harms. Then there's more rules. Then that only tells us if the plan can use coverage criteria. If they do use coverage criteria in that scenario, the criteria have to be publicly accessible, based on current, not outdated evidence, based on widely used treatment guidelines, the kind that professional societies would publish for treatment guidelines, and or widely used high quality clinical literature, not www.payerwatch or RichelleMarting.com. That's not widely used clinical literature, high quality clinical literature. At least mine wouldn't be high quality clinical literature. We're talking peer reviewed studies. We're talking clinical trials. That's the type of clinical literature that CMS expects these to be based upon.
Really talking professional society journals, American College of Emergency Physicians, Society of Hospital Medicine sort of sources then.
Yeah, exactly. And peer reviewed. So not just an editorial comment of
Correct.
one particular physician who's proposing a novel idea, but actually something that the professional society is representing as kind of their position statement. That's the kind of widely used treatment guidelines that CMS is talking about here. Let's go to the next slide. So I mentioned that an organization determination is a decision about coverage and payment, a decision in whole or in part to refuse to provide coverage or payment. One of the things I hear frequently when we're talking about the 2-midnight benchmark and basic Medicare benefits are that we know hospitals and Medicare Advantage plans typically or often have contracts with one another that dictate kind of the rules of the relationship, the rates of payment, and other contractual terms. And typically in those agreements, there's language that the MA plan can develop certain kinds of policies and that the hospital follows those policies. That's just a contractual agreement that the parties tend to reach. However, despite whatever may be in a contract, we have regulatory language under the Medicare Advantage program that says decisions related to coverage and payment can only be reopened for good cause, no matter what your contract says. The language that says an MA plan has a right to audit, to review and inspect medical records and payment. Sure they do, but it cannot override federal rules that say they cannot reopen coverage decisions, organization determinations without good cause. That includes decisions related to prior authorization. We're going to come back to that in just a little bit when we talk about post-claims issues. Next slide. So this is the third of those materials that I referenced at the beginning that you have bookmarked or saved to your desktop. February 6, 2024. CMS wrote a memorandum to all Medicare Advantage organizations, and it is worth the 15 pages of reading. It's an FAQ, and it has really great text in there to share with MA plans. And one of those explanations that CMS gave weighed in on post-claims review of services that were prior authorized, like inpatient status, prior authorized at the time of the admission. And plans said, wait, does this mean we can't review services later on? And CMS says, well, if an MA plan approved the furnishing of a covered item or service through prior authorization or some other pre-service determination, it may not deny coverage or payment later on the basis of lacking medical necessity. And it cannot even reopen that decision about inpatient status, about prior authorization without good cause.
I think one of the big challenges that I suspect a lot of our audience deals with here is recognizing and recording the prior authorization, the peer-to-peer that took place and agreed to inpatient, and then being able to annotate the record and keep track so that when the auditor comes knocking, he can say, buzz off, we already had an auth here and you're not showing good cause. And I've seen some really squirrely rationales for good cause that we probably don't need to go down that rabbit hole here. But it's telling, I think, because we do see time and time again a prior auth, a peer-to-peer, an agreement, a meeting of the minds, and then 6 months later, the auditors come knocking. It's almost as if the left hand deliberately doesn't talk to the right hand.
Yeah, that's such a great point, particularly if you never get that written authorization after a peer-to-peer. And I absolutely agree with you. I see more hospitals now working on a way to almost like a call note with a patient, capture that conversation as part of the medical record. That I, Dr. Smith, had a peer-to-peer with Dr. Marting. This is the date, this is the time, a call reference number if you can get one. And this was the decision at the end of the call. And confirming, even some scripting during peer-to-peer to confirm, okay, I just want to confirm the prior authorization number, and we get that number and memorialize it in the record. It's especially important if we don't yet have an authorization in writing for this exact purpose, because when we get a post-claim review of whether this hospitalization was appropriate for inpatient versus observation, the first thing I'm going to do is go look and see if inpatient was authorized. If it was, that's really what I'm focusing my my appeal on, the inability to even reopen that decision.
And that's got to be, I think, a takeaway, inflexible best practice for everybody listening is that go-to and that exercise that you just spoke of.
Yeah, and let's see, Eric, let's go to the next slide. Hopefully I put in here the definition of good cause. And if I didn't, I'll go through it now. Good cause means you either intentionally withheld information from the plan that would have changed their decision at the time that they gave authorization. Good cause is not what manifested the rest of the hospitalization. Because the
So,
decision to admit or admit as inpatient or make observation, it's based on what everybody knew at the time that decision was being made.
so,
Or new and material information comes to light.
so we go
Go ahead.
back to, and this was an interesting animated discussion at the NPAC meeting, I think between, I'm not going to remember who was speaking of this, but typically patients with DKA that come in with severe acidosis or heart failure, which I think was the point of contention at the NPAC meeting in Chicago, where they come in with decompensated heart failure. The intention is greater than a 2 midnight stay, and miraculously 6 or 12 hours later, they're better, but the conversation and the approval happened while they were acutely ill. Miraculously and unpredictably, they got better after that line in the sand was drawn. And that does not constitute good cause for a payer to come back and say, well, they got better and we're out 12, 24 hours later, even though at the time we agreed with you they were critically ill and likely would need it and did in fact need inpatient.
Yeah, and it's so interesting because you will hear plans say, we are not subject to the 2 midnight presumption. Benchmark versus presumption. Benchmark is the physician's judgment that the patient will require 2 midnights of hospital care. MA plans are bound to that. They are not subject to the presumption, which says so long as it did actually manifest in at least 2 midnights, don't go back and reopen that stay and review it. So it's technically true. They're not bound by the presumption. However, because MA plans have elected to use prior authorization for inpatient status, which traditional Medicare does not have, they still cannot reopen that decision without good cause. So good cause, if the patient got better, that is not good cause. That doesn't change anything about what everyone knew at the time they were making the decision of inpatient versus observation.
Perfect.
Okay, so pre-service issues. Let's talk about this prior authorization piece a little bit more. When a patient is coming into the hospital, we give notice of admission. We're asking for prior authorization to make the patient inpatient instead of observation. And CMS has clarified when prior authorizations can even be used, what they can look for, and my favorite, who has to decide the outcome. So let's go to the next slide, Eric. There's really only two situations prior authorization can be used, but they're pretty broad. One is to confirm the presence of a diagnosis or some other medical necessity criteria. So if a payer or traditional Medicare has a policy that says a particular test is only covered when a patient has particular diagnoses, that's a circumstance prior authorization can be used. Or the second one, this is really the broad one, to ensure an item or service is reasonable and necessary based on standards in some rule. Cannot be used for emergencies, so we can't prior auth or deny prior auth services in the emergency room. Prior authorization cannot be used to deny inpatient status for an inpatient only procedure. I don't see that a lot, but it does come up every once in a while. And we can try to address that through peer-to-peer or through appeals. And the last piece, that once an MA organization gives prior authorization, they cannot deny coverage and payment on the basis of medical necessity. You may find plans describing their review process not as a medical necessity decision, but as a payment policy, a contract decision. And I don't buy that, and neither does CMS. CMS has some guidance in that February 6, 2024 memo that says we've heard plans describing some of their decisions as payment policies, kind of as a circumvention of the definition of an organization determination. And we don't buy it. An organization determination is a decision to deny coverage or payment in whole or in part based on the type or the level of the service, inpatient versus observation. Let's go on to the next slide. My favorite piece of this, though, was who gets to make the decision about prior authorization. And the good news is anybody can approve. AI can approve, algorithms can approve, non-physician Richelle Marting could approve. However, if there will be an adverse decision, something in whole or in part denying coverage or payment, that's when there are rules for the MA plan about who can make that decision. It must be either a physician or another professional with expertise in the services at issue, including knowledge of Medicare rules. So it doesn't necessarily have to be a physician all the time. If we're talking about authorization for physical therapy services, a physical therapist could make that decision. But if we are talking about a decision to admit the patient for inpatient care, it should likely be a physician or a professional whose state licensure allows them to admit patients to the hospital. They don't have to have the exact same specialty as the admitting provider, but they need to have expertise in the services issue, not familiarity with. But Medicare used the phrase expertise in the services at issue. I had one hospital communicating some complaints and concerns to me about their inpatient status with a particular plan, and they gave an example of a patient being admitted for a medical admission. They went to peer-to-peer with the plan, and the professional on the plan's side coming to the peer-to-peer was a dentist for a medical admission. But physical, not oral surgery, but systemic chronic conditions prompting the admission. So that's an example where we may say this is not a physician or professional with expertise in the services at issue. And then the last piece, knowledge of Medicare rules, I think is important when you're going into a peer-to-peer, and we've developed for some of our physician advisors some scripting going into those peer-to-peers. It's almost like a deposition where we're asking questions and we're eliciting responses because, Dr. Smith, we're wanting to start memorializing these conversations. And if this conversation to authorize an inpatient level of care doesn't go the way we want some information about what that peer on the plan side said. So we may say things like, is our physician's judgment unreasonable that this patient would require 2 midnights? Oh, no, I don't think it's unreasonable. Well, you do know about the 2 midnight benchmark. It's that the attending physician, the admitting physician's judgment that the patient will require 2 midnights is reasonable. And you've just said it's not unreasonable. I've heard physicians tell me the plan's peer said, I don't know anything about the 2 midnight rule. Well, that becomes a problem with this language because that physician on the plan side has to have knowledge of Medicare rules, whether it's inpatient status, skilled nursing facility requirements, inpatient rehab, not just applying Milliman or Interqual, but the 2 midnight benchmark. Let's go to the next slide. All right, so we probably all know this really well, but there's really 3 ways we get hospital inpatient status. We've got our inpatient only procedures. We have the case-by-case exception for short stays. But the 2 midnight benchmark says under federal regulation 42 CFR, I think it's 412.3, an inpatient admission is generally appropriate for coverage and payment when the admitting physician expects the patient to require hospital care that crosses 2 midnights. That's the rule. That's the regulation that is fully established under traditional Medicare, and MA plans cannot create criteria that are more restrictive or that vary from the 2 midnight rule. They could cover inpatient care spanning 1 midnight. That would give greater access to a higher level of care, but they can't be more restrictive. Next slide. All right. Back to that February 6, 2024 memo. I think this is the 3rd or 4th time I've referenced it, and I am telling you there's some good stuff in here. Put it in quotes so I don't mess up what CMS says. An MA organization can evaluate whether the admitting physician's expectation that 2 midnights of hospital care was reasonable. They can make that assessment, but it has to be based on the 2 midnight benchmark and consistent with that benchmark. That evaluation by the MA plan should defer to the judgment of the admitting physician as long as it was reasonable. I put that in bold because if we were to rewind several slides back and look at the circumstances when an MA plan can potentially use their own criteria or commercial criteria like millimeter interqual regarding regarding inpatient status or level of care. This could be the circumstance where additional information or guidance is needed to clarify whether the admitting physician's judgment was reasonable. I think that becomes hard for an MA plan to support when the time of the peer-to-peer is happening on day 4 of the hospital stay. How and why was the judgment of the admitting physician unreasonable? And we can't just use millimeter interqual and their kind of status recommendations. The guidance that we're relying upon has to stand for the position that the MA plan is advancing. And they would be advancing that the admitting physician's judgment that this patient would need 2 midnights of hospital care was unreasonable. So what is it in the millimeter or the interqual or some other guideline that's being relied upon that suggests we overcome this deference to the admitting physician and that the admitting physician's judgment was unreasonable? Next slide. So I mentioned that once a Medicare Advantage plan authorizes inpatient status, they cannot reopen that decision with good cause. And this is true prior to 2024. You may still see some, it's 2025. You may still see some 2023 admissions opened and reviewed by MA plans or their review contractors. And in those reviews, you may see the plan or their contractor suggesting that inpatient status is not covered or not approved. It should have been observation. MA plans can reopen, can look at claims that have been submitted, but not if they authorized that status. If it was never authorized or denied, they can review that decision, no problem. But because the vast majority of plans use prior authorization for the inpatient status or the inpatient level, there's a caveat for the plans that they need to know and that you need to know. They cannot reopen that decision about inpatient status without good cause. Prior to 2024, this was still the rule because the Medicare manual, the policy, even before we had a regulation, said for MA plans, Prior authorization is advance approval of coverage and payment, and that it can't be changed later based on medical necessity. Let's go to the next slide. All right, so here's that quote from the 2024 memo that I love so much. Our plan's able to do post-claim audits and deny payment and still be in compliance with the effect of a prior authorization. And CMS said, yes, but. Yes, but if the MA organization approved the furnishing of that service through prior authorization, they cannot later deny it based on medical necessity, and they cannot even reopen the decision for any reason unless there's good cause. And good cause is evidence of fraud, fault, you intentionally withheld information at the time you were seeking authorization for inpatient status, or you materially misrepresented something about the patient and their condition, or new and material evidence that was not known or available to the plan becomes available. But CMS also says, by new and material evidence, we're not talking about what happened the rest of the hospital stay, because of course that wasn't known to the plan. Neither was it known to the physician or the hospital, because that doesn't matter when the plan is applying the 2-midnight benchmark. And that is the standard that they have to stick to in making the decision on inpatient versus observation. So whatever transpired after that decision cannot be used as good cause or new and material evidence to reopen their decision. Next slide. All right, so I think I've covered this one, but I still like to quote it because I think it's so important. That in a pre-authorized service, it would be a violation of the regulation to later deny payment based on a decision that the level of care was not medically necessary. Next slide. All right, so the response that you might get from plans, this isn't a medical necessity decision. This is based on our payment policies, and CMS can't interfere with private contracts and the payment policy that we have entered into, plan and hospital. Next slide. This is another provision from that 2024 memo. I put it in quotes because I reference it so often. CMS says, we've heard that MA organizations characterize these reviews as payment reviews, and that these reviews are not organization determinations or level of care or medical necessity reviews. And CMS says in bold, well, I put it in bold. CMS says verbatim, we disagree with those characterizations. Next slide. It is a decision in whole or in part to reduce coverage or payment for medically necessary services. Now, I put up here on the slide an example of the CMS complaint form, and I use this a lot. I use this both when our physician advisor on the front end is communicating to me that a Medicare Advantage plan is denying inpatient status in a situation that we believe meets the 2-midnight benchmark. We file a complaint. And in this complaint, my goal is not to get the MA plan to change their decision. My intent is not to get a reversal of their denial. My intent is to have a complaint on file against this particular MA plan that then goes into something called the complaint tracking module, and it's used as a complaint against the plan, which is a little row on their star ratings. And when we start to have this happen over and over for the same plan, we've started to see some interesting patterns I'll tell you about in just a second with our last minute or two here. Let's go to the next slide. A few tips. I really do encourage you to use this complaint process. It has been, while it has taken a while, it has been very effective for us in a couple of situations. We use it on the front end just to memorialize concerns about what we hear the plan's physicians saying. If we don't think they're an appropriate specialty, I don't know anything about the 2 midnight benchmark. I think your physician's judgment was reasonable, but I've been told to apply interqual only. Those are the types of things we put into the complaint. As you can see, I have some kind of templates and some language that I put into mine, and I submit these just routinely. Every time our physician advisor communicates it, I send one out. I also use this on the back end when plans reopen their decision. And I am so excited to tell you, we've had about 15 of those overturned, and we were able to retain our inpatient payment because of plans responses to our CMS complaint that we filed. Next slide. All right, so I've mentioned that this is part of the star rating process, and I know we're right at the top of the hour, but look at the average star rating on this line item just over the last couple of years, dropping drastically. And I don't remember which plan I selected in looking this, or if this was the overall national average, but this is why. And you hear plans really focused on their star ratings. When you file a complaint, this is where it goes for that MA plan. Next slide. Right. I'm going to leave this on the slides. I know you can read it later, but this is just kind of what to expect in filing the complaint process. You send it to an email. You get a CTM, which is a complaint tracking module number. The plan may reach out to you within 30 days with a written response of their findings. Next slide. Track these. Track the complaints, track the responses, track the issues. Work with your managed care team if you're not already, because in the managed care contracting hat, I love to get those examples and share during our meetings, particularly when we're focused on MA plan issues, the types of problems that we're having, and how many complaints we've submitted for that plan alone. Next slide. I think we've got one or two here, and I'll turn it back over to you, Dr. Smith. Let's go on to the next one, Eric. There we go. All right. So obviously we could probably spend an hour just on the CMS complaint process, but I do want to raise that as an avenue that hospitals and physician advisors have to illuminate some of the challenges with MA plans following those regulations. And that really is the point. Not to get an overturn, not to get a change in the plan's decision, but to highlight for CMS the magnitude to which those rules may not be followed or being followed.
And I think, Richelle, to echo on what you're saying and going back to the star rating, I think folks listening to keep in mind that star rating directly ties to financial benefits to the MA plan, and a drop of an entire star can result in the loss of potentially millions, hundreds of millions of dollars in revenue based on the plan size. That said, I last week had a call from a small MA plan in Michigan where we had filed 2 complaints. And the conversation, and I just wanted to advise folks, don't take the bait, was that in the future, rather than filing complaints, could we just have an off-the-record discussion, and we'd be happy to resolve any differences with you. We really don't think that a formal complaint's necessary. Here's our direct contact number. Anytime you have any concerns, please reach out to us. And take it for what it's worth. But I think, as Richelle has said, the more that folks on this call become comfortable and develop a process with escalation and filing these complaints, the more sunlight we get into this area, and the greater our ability to amplify our voices becomes. So if I were going to take home anything as an ask to the audience today, it would be the last section of this talk, which is when something is you believe is in violation of what Richelle's talked about today, speak up, make your voices heard, and let's use this leverage. I think that has been lacking for far too long, because it is having a direct and immediate impact on plan behavior that is long overdue.
Well, I think that just illustrates 2 complaints prompted that kind of response from the
Yes.
plan. So it just highlights how important and what a focus
The
area it is.
thing that was even more hysterical was one was a 14-day stay on a ventilator that they thought was not medically necessary. So you start with that premise and it just goes downhill from there. And you're like, so yeah, be wary of strangers offering you candy. There's little or no good that comes out of it. And there's a reason that they start acting nice and giving you contact numbers. So
Right.
absolutely. So I
Well,
can't
we want
say
to.
thank you enough today. Um,
Of
do we
course,
want to
of
stay
course.
over for some questions or do we want to answer questions offline?
I think we probably better do it offline. We're 5 minutes over our time slot, so just out of respect. There were a lot of questions that came in, so I do want to. I will email these out to Richelle and Dr. Smith, and then we will send them out to all the attendees. Make sure you get answers to that. But thank you again, everybody, for attending. We're really grateful. Richelle, we're really grateful for you, for your
Absolutely.
insight.
Yeah. Thank you for having
I
me.
Yeah, no, thank you. Thank you for your time and advocacy for the people listening. I can't say enough for the work that you do and the voice that you bring to this area. Um, all too often we clinicians are looking for legal insight and guidance, to guide what we think we should be doing. And having you as a voice and an advocate in this community has been long overdue and is greatly appreciated.
Well, I'm glad to be a part of it.
Thank you.
All right. Well, thanks, everybody. Don't forget to register for the next one. Go to adam.org and get on that as soon as you can. Have a great rest of your day.
Take care. Thanks.